Hi, this is Miriam Voss, and I'm going to be speaking to you today about pediatric non-alcoholic fatty liver disease, challenges in clinical care. Before I start, I'd like to thank Melanie and the other organizers for inviting me to give this talk, and I'd like to thank all of the moderators out there in the rooms who will be leading the discussions today. So first, my disclosure slide. As you can see here, I have research funding from some industry groups, as well as Foundation and NIH, and then my consulting at the FDA, NIH, and University of Arizona. Okay, so things that we're going to cover today include to discuss when to biopsy and when to rebiopsy in pediatric NAFLD, also to understand dyslipidemia in the setting of NAFLD, and then finally to discuss treatment with vitamin E. And before I go into those three objectives, I'm going to go through some background on NAFLD. So NAFLD terminology can be a little bit tricky. The term NAFLD, N-A-F-L-D, is an umbrella term that covers the full spectrum of disease. More specific terms include NAFL or NAFL, which is often used to refer to simple steatosis, which is seen there on the left-hand side of the slide. Simple steatosis includes macrovesicular fat, but can also be a mixed picture with some macro and mostly macro and some microvesicular fat. NASH, or non-alcoholic steatohepatitis, is the form of NAFLD that includes some inflammation, hepatocyte ballooning, and fibrosis, in addition to the fat in the liver. And then finally, I'm showing you here a picture of cirrhosis, or end-stage NASH, which shows bridging fibrosis in addition to the steatosis and inflammation. The cirrhosis can be so severe that the scar tissue or the fibrosis completely replaces the parenchyma of the liver, and there's no fat being seen. But in this picture here, you can see there's still some fat as well as the extensive fibrosis. So how common is it? Well, it's extremely common, and not only in the United States, which I think you can tell from your clinics and the number of referrals. So this picture shows you prevalence rates in obese adolescents across the world. On the left-hand side, you see the United States, which was estimated at 24%, Mexico, 42%, in Europe, 28%. There's also Italy there at 53%, China, 77%, and then Japan, 24%. So you can see this is a worldwide problem and not just something that we're struggling with. So who gets NAFLD? Well, it is more common in boys than girls, and this is shown probably by the kids coming to clinic. I certainly get more boys referred to me. It also has a very strong difference in prevalence by race and ethnicity. Hispanic children in the United States have it by far and above other races and ethnicities. Whites are a little bit less common, and then African Americans or blacks are relatively spared and have the lowest rates. Asians don't show on this figure in this study, but they are somewhere, in some other studies, they're somewhere between Hispanics and whites. In the U.S., Hispanic is actually a very diverse category, but most of the children in these studies were Mexican American, which does seem to be a group with a particularly high rate. What about age? So younger children rarely present with NAFLD. On the graph here, you can see 2 to 4 year olds had a very low rate, and then it went up in the 5 to 9 year old category, up over 10% in the 10 to 14 years, and then greater than 15% in the 15 to 19 years. The most common age of presentation is pointed to here by this arrow, and that's 10 or 11. And that may be partly driven by the physiology of the disease, but it also may be partly driven by the fact that there's a recommendation to screen 10-year-olds with an ALT. So why would it present at this age or seem to start or be more common here? Well, there's not a longitudinal study that looks at children, starting at age 5 and then looks at their livers, annually to see when it actually starts. But we do have this study by Jeffrey et al. that shows that insulin resistance really starts to rise in the 8 to 9-year-olds. And so somewhere here between 8 to 10, their HOMA-IR really takes off. So they're much more insulin resistant. And because of the close link between NAFLD and insulin resistance, makes it likely that this physiology of early puberty is playing a role in this, that the fact that we see so many kids present with NAFLD at this time period. But again, as I pointed out, I think this needs more study. So NAFLD, is it just a liver disease? Is it just in the liver? Well, no. We know it's associated strongly with visceral fat mass, which is expanded and inflamed. It's really a systemic problem. So they have a systemic increase in inflammatory cytokines. They have increased insulin resistance, increased free fatty acids in circulation. They also have increased atherosclerosis. So even studies in adolescents have shown increased atherosclerotic plaques and non-invasive markers of cardiovascular changes. And then in adults, cardiovascular disease is strongly associated with NAFLD. Type 2 diabetes, which goes hand in hand with this early insulin resistance, is also strongly associated with NAFLD. So I've really begun thinking about this as a systemic disease or a syndrome. It's not just in the liver. And the kind of the succinct list of clinical conditions associated with it is shown here. So NAFLD, visceral adiposity, triglyceride to HDL ratio is increased, the acanthosis nigricans, and then insulin resistance. This is a classic collection of features that you'll see in the NAFLD patients. And one of the things that this reminds me of is how many different physicians one child can end up with. So, for example, they might come to me for the NAFLD. They'll go to the preventive cardiologist for their triglyceride to HDL. They go to the endocrinologist for the last two here, the acanthosis and the acanthosis nigricans and the insulin resistance. And then, of course, they're seeing their pediatrician too. So the poor child is ending up with four doctors for what's probably really one condition. Okay, on that note, how do we screen and how do we diagnose NAFLD? So I mentioned obese children are recommended to be screened for NAFLD at age 10, and that's from the expert committee guidelines that came out a while back. So many children will be presenting in your office at that age. Overweight children should be screened at age 10 if they have risk factors that place them at higher risk. And some of those factors that have been listed include being Hispanic because of the known increased prevalence rate, and then also if they have a family history of NAFLD. If they have type 2 diabetes, they have an increased chance of having NAFLD and having a more severe form. And then right-sided abdominal pain is a symptom that's been associated with NAFLD, and so that can be considered a risk factor. It's not very specific or sensitive, but if they do have right-sided abdominal pain, NAFLD is something to consider. One that I forgot to put here on the list is sleep apnea. So sleep apnea is a risk for more severe fatty liver disease and should be considered a risk factor. So once the child's been screened with an ALT, what's normal? This study by Dr. Jeff Schwimmer et al. Very nicely showed that you can't trust the the normal range that comes on the lab sheet. And so they looked at 43 children's hospitals and looked at what range or what upper limit of normal was on that guidance. And they found a very wide range, all the way up to some of them were even in the 60s and 70s, and there was a mean of 53. So they looked at the NHANES population and looked at the 95th percentile for an ALT in normal weight healthy children in order to get an accurate assessment of that. And they found that the upper limit of normal for children, for boys, should be 26 and for girls 23. So these are really the standard of care today, and it's no longer appropriate to use the ones that that are on the lab sheet unless they've corrected and updated these. And so one of the things we did in our hospital is we met with the lab director, and then we were able to get the normal range adjusted to be more appropriate for children. So once you get the elevated ALT, or once a child has an elevated ALT, one of the questions I get a lot is, okay, what next? Do you jump into a big workup if they have an ALT of 32 or 41, or, you know, kind of where is that cutoff to start really down that path of further workup? And so this is an example algorithm that I put together for the pediatric gastroenterologists in my community. And you can see here there's a lot of choices, but on the left-hand side, if the ALT is 30 to 50, I suggested that they repeat it within 1 to 3 months. If it was normal on the repeat or decreasing, then there's some steps here, so they're kind of off the hook, or they could repeat it if the child's still overweight. If the ALT starts out higher, 50 to 100, I recommended repeating it sooner. And if the ALT was greater than 100, I recommended that they repeat it really sooner. And what, you know, ASAP means is it 1 day or a week later. That, I think, was left up to their judgment. And really there's no evidence for these numbers, so I just picked 50 to 100 and greater than 100. It would be helpful to have studies kind of looking at this and how, where the cutoff should be, but unfortunately at this point it was really just opinion. So just a comment, you're welcome to use this algorithm. I just really put the caveat on it that it's not evidence-based. It's something that I came up with just to try to help with that clinical decision-making. Okay, so what's the typical pathway to diagnosis of NAFLD? So after you have the ALT, it's been repeated, they have a chronic hepatitis of some sort. Next is clinical exclusion of medications. Alcohol use should be excluded. It's not as commonly a problem in children, clearly. The next step is serologic exclusion of other chronic liver diseases. And so that list includes things like autoimmune hepatitis, Wilson's disease, alpha-1 antitrypsin deficiency, hepatitis B and C. I forgot on that list celiac disease, so that should be considered as well. And then after those have been ruled out, the next thing to do is to confirm that they do have fat in the liver. So NAFLD is a diagnosis of exclusion, excluding these other things that can cause chronic liver disease, but it's also a diagnosis made by proving that they do have fat in the liver. And I'm going to talk about these 3 modalities here of looking at fat in the liver. So ultrasound. This is a little bit of a tricky one because it's something that we've all been used to sending routinely, but unfortunately the studies show that it has very low sensitivity for fat versus not much fat. So if the fat level in the liver is low, less than 30%, 33% in some studies, then the ultrasound has very low sensitivity. In other words, it will miss it. It's also not very specific. So if there is an extensive amount of fibrosis or even possibly inflammation, the ultrasound might get read as increased echogenicity, but in fact not be fat. And increased echogenicity is usually interpreted as fat in the liver. So it can be a misleading test. It is a very useful test for detecting structural lesions such as cysts and tumors. What about MRI? This is a modality that's improving rapidly. It's very precise. It has high sensitivity and specificity. It's not available yet clinically in most centers, but it is available in many research centers and is starting to be used frequently in research studies. Some downsides are that it's expensive. It's also difficult to do an MRI in very young children. Anything under 6 or 7 probably would require sedation. And then the other caveat is that the cutoff for MRI and MRS-based fat measurement varies and will need to be determined based on each MR method. So that test is not really ready for prime time, but when it is available, it will be great because it's very sensitive and specific. We do a lot of MRI-based research at my center, so I'm just going to show you a couple pictures because I think it shows how exciting this modality is. So here on the right, where the arrow is pointing, is an area of focal fatty sparing. So there's actually no fat in the liver right there, but the rest of the liver is just dark with fat, and in this particular liver, also with iron. And this is a typical reading that would come back once this MRS-based method is clinically available. So the radiologist would get this cute little colorful graph, and up here it shows that the lipid is 8.3%. So clearly elevated, not severely elevated. This particular person also had moderate amounts of iron in the liver, and so this was one of the adult volunteers, I think, or one of the adult patients, because we don't typically see elevated iron in the kids. So the impression for this particular scan was mild liver fatty accumulation, measuring 8.3%, and then moderate elevated iron. So you can see that once this is clinically available, it will be a very useful test. And then finally, just the other thing that's kind of interesting about MRI is you do get very detailed pictures. And so at our center, we can see, of course, severe fibrosis like this, cirrhosis, but you can also see the moderate amounts of fibrosis on the skin as well. MRE, or MR elastography, is another technique that will even more precisely measure fibrosis, and that's a research technique that's coming along fast as well. So I think the future's bright. Right now, we're a little bit limited in our imaging that's available clinically. So once you prove that they have fat in the liver, what other diseases do we need to make sure we rule out so that we know that this is NAFLD? Well, one of the ones that I don't think we see very often, but is very important to distinguish, is lipodystrophy. And I borrowed this slide from my friend Dr. Rebecca Brown at the NIH. Because obesity and obesity-related diseases like NAFLD is very common, patients with lipodystrophy often get misdiagnosed and are kind of mixed into the population. These are red flags listed here that she suggested in order to try to differentiate and not miss a patient with lipodystrophy. So obese patients can have very abnormal fat distribution. So the person here in blue is kind of a typical person who has some fat abnormal distribution but does not have lipodystrophy, as compared to the person on the right who has a very severe unusual fat distribution, and so that person did have a lipodystrophy. Another red flag is metabolic disease that's out of proportion to the obesity. And I've had several patients present to my clinic that way. So they were actually a very muscular form of lipodystrophy and did not have subcutaneous fat deposits, but had severe NASH. And so that was a red flag that this was not your typical NAFLD patient, but rather was somebody with lipodystrophy. Also, family history of lipodystrophies, and then lastly, there's some genetic testing for lipodystrophy. The reason it's important to differentiate these two is because there is now leptin is available as a therapy for patients who have a leptin deficiency and lipodystrophy. So they have a completely different treatment pathway. Other conditions that are associated with hepatic fat include Wilson's disease. I have that one highlighted in red because I think it's one of the trickiest ones to try to differentiate from NAFLD, and I'll tell you more about that. Hepatitis C is associated with steatosis, medications such as steroids, amiodarone, and other ones, mitochondrial disorders, uncontrolled diabetes, alcohol abuse, of course, but hopefully you're not seeing that in your clinics, starvation or anorexia, and then lastly, LAL, or lysosomal acid lipase deficiency. So all of those can have steatosis and should be differentiated from NAFLD. So can labs replace a liver biopsy? Well, the bottom line is that no clinical labs can accurately distinguish NASH from not NASH. And in a case series that was published in Gastro, when patients were diagnosed without biopsy, and then those were compared to biopsy, 15% of the cases were not NAFLD. So in other words, without that liver biopsy, they would have been misdiagnosed. The ALT and GGT can help you decide who to biopsy because they are higher in kids with more severe disease in NAFLD. And lastly, as I pointed out before, Wilson's is tricky. So I have an example in my clinic of a teenage boy who presented with fairly classic NAFLD features, and he had an elevated BMI. It wasn't super elevated, but over the 85th percentile. And he had a fairly normal ceruloplasmin as well, so it was a bit tricky. But I ended up pursuing further testing, and it turned out that he had NAFLD. But one of the scariest parts of his case was that his biopsy came back red as NAFLD. So the pathologist had described the histologic findings and then concluded that this was non-alcoholic fatty liver disease. But the copper tissue level in the liver came back very high, so he had Wilson's. So Wilson's disease is called the great imitator for a reason, and the pathology can look just like NAFLD. So who do you biopsy and when do you biopsy them? So this is my opinion because we don't have evidence to prove all these different points, but what I do is if I biopsy if the diagnosis is uncertain, so if any of those screening tests have come back with a slight abnormality or not quite right, or they're not quite as overweight as I think that they should be, or they don't, or their ALT doesn't respond to some lifestyle changes. So if the diagnosis is uncertain, they should be biopsied. If the ALT is greater than 80, and the reason I say that is because a higher ALT is associated with an increased risk of fibrosis. The risk is actually 5-fold over somebody who presents with NAFLD who has an ALT that's lower than 80. I also biopsy if the ALT has been elevated for more than 2 years. And the reason I do that is because if the disease has been there longer, then I think they have a higher chance of having fibrosis. And just anecdotally, that has played out and has been true in my patients. And then lastly, if the child is on a potentially hepatotoxic medication or needs to start one, then I think it's important to know exactly what's going on in the liver. What about repeating the liver biopsy? Well, there's really no evidence for this. I think that repeating the liver biopsy may be useful to assess progression or non-progression or improvement of fibrosis if they had NASH and or fibrosis on the first biopsy. So if they had a super mild biopsy the first time, they only had NAFL, I don't recommend a repeat biopsy. But I do offer a repeat biopsy if they had NASH and particularly if they had fibrosis on the first biopsy. That helps me to provide prognosis for that child to that family, and it also helps with decision making. So if there's a multidisciplinary program available and the family has not prioritized that, or I haven't helped them get into it, if we repeat their biopsy and they've progressed in their disease, it helps motivate the decision making there to really work hard on getting into a program and doing some substantial changes so that they can lose weight and improve their disease. Okay, what about dyslipidemia? So this is a kind of a tricky one. I think we get these lipid panels and it's like, what do we do with this? But it's actually fairly simple. And so this is a table here from the most current lipid guidelines, and this is what to do with these different lipids. Now, I'm going to focus on the triglycerides and HDL because that's the most common abnormalities. For questions about LDL abnormalities, I'm going to let you go to the guidelines themselves. So the triglycerides are down here, and if they're borderline high or high, which is greater than 100 and greater than 130 in children 0 to 9 and then 10 to 19 respectively. So if it's high on the first one, the guidelines suggest that the next step is to repeat the fasting lipid panel. So you need to have 2 fasting lipid panels, and then you take the average of the results. If the fasting triglyceride level is between 200 and 499 and that's the average of the two, the first line treatment is what's called the Child 2 triglyceride diet. And basically, the Child 2 triglyceride diet is carbohydrate reduction. It's that simple. And it's because The carbohydrates enter the liver through the portal system, and they stimulate de novo lipogenesis, or making new fat, and they increase the size of the VLDL and put more triglyceride into circulation. So the best treatment for high triglycerides is to reduce carbohydrates. Now, the second line therapy, or if the carbohydrate reduction fails, is to go down here and start a fish oil supplement. But that's not, you don't start with that. You start with carbohydrate reduction, which is great because, as I'll tell you later, that's also a great treatment for NAFLD. The fish oil supplement it only has grade D evidence to support it, and I will say anecdotally I've had very little success with improving triglycerides in my clinic using fish oil. I think it's partly due to non-compliance because I don't think the kids like those big oily looking pills, but hard to know. Okay, so what if the triglycerides are greater than 500? So the guidelines say consider referral to a lipid specialist. The best part about that in my center is that for a long time I was the lipid specialist. So this is what you do if you are the lipid specialist. You put them on the child 2 triglyceride diet, give them fish oil along with that diet, and then consider the fibrates and niacin. I don't use niacin because of the side effects, and so I don't think that it would be tolerated in children. I have used gemfibrozil in children. I haven't seen a great response. This is a big dilemma, the persistently elevated triglycerides. There are no studies in children or adolescents proving what works, and the caveat in the guidelines is that they may need multiple medications. Okay. That's treatment of dyslipidemia. Let's talk about treatment of NAFLD. So what about metformin? So there are 2 studies I'm showing you here that looked at treatment of NAFLD in children with metformin. And unfortunately, both of them were not exciting. So the first one by Nobili et al. Showed that metformin plus lifestyle interventions versus lifestyle interventions alone, they looked at these 2 treatments and found that both groups improved steatosis, inflammation, and ballooning, but that there was no difference between the groups. A much larger randomized controlled trial by the NIH NASH Clinical Research Network showed that there was some benefit to metformin treatment, but it was not significant for the primary outcome, which was ALT improvement. They also, the second trial, the randomized controlled trial here, had some challenges because the dose that they used of metformin was lower than is typically used. It was 500 milligrams BID, and so the children who received it didn't have the same change in insulin resistance that you would expect. So it's not. I think this is not the final answer, but the current guidance is that there was no improvement with metformin. That said, metformin is useful in some patients with NAFLD, and that would be your patients with NAFLD who also have prediabetes or type 2 diabetes. And so in consultation with the endocrinologist in your center, there are some children with NAFLD who may benefit from metformin. There are no specific recommendations right now for when to use metformin, even for prediabetes and type 2 diabetes. In my experience, what I do is I consider it in cases where they clearly have severe insulin resistance, so very high insulin levels, or I send them for an oral glucose tolerance test, and so they have abnormal results on that. The other case that I've used it is for several children who had very severe acanthosis nigricans along with their NAFLD, and they both had very nice response in that the acanthosis nigricans got much better and was much less disfiguring, but they also improved their ALT. I didn't repeat biopsies in those kids, so I cannot confirm for you that their NAFLD improved definitively, but it was promising. Okay, what about ursodeoxycholic acid? Well, we don't even have to discuss it because it's not useful in NAFLD. So then finally, what about antioxidants? So there's been 2 recent large randomized controlled trials comparing vitamin E to the insulin sensitizing drugs and then standard of care, which is lifestyle. And one was in the adults in the NASH, the adults in the NASH Clinical Research Network, and then also in the pediatric group. And both trials were technically negative for vitamin E. Both showed some benefit from vitamin E. They showed that there was some improvement in inflammation, steatosis, and ballooning of hepatocytes. It's important to note that the treatment dose in children was 400 IUs BID and that they gave the natural form. So if this is chosen as a treatment for children with NAFLD, that dose is what was studied, and then also that it was the natural form of vitamin E. A caveat is that if vitamin E is used to treat NAFLD, it should be used to treat the more severe forms of NAFLD, because that's what was studied in the trial, and then also that it would be recommended to look at a repeat biopsy if you're using it to treat NAFLD, because otherwise you don't really know what your endpoint is. Okay, so what about lifestyle changes? I mentioned that that's the standard of care. Increasing physical activity and improving nutrition absolutely improves NAFLD, and that is the first-line treatment, and it's important that all children with NAFLD and families who have these kids understand that that's the focus. And actually, just that's one of the reasons why many of the hepatologists choose not to use vitamin E, is because even though we know there may be a small benefit, sometimes that vitamin E pill can be distracting from focusing on physical activity and nutrition. Lifestyle changes have been proven to improve steatosis, they improve the ALT, they improve histology, so inflammation and ballooning. There's no study yet showing that it improves fibrosis, but in the placebo groups in these trials, you do see improvement in fibrosis in a percentage of the responders. So what do you change in lifestyle? So I'm not going to give you a whole lecture on sugar and sugar drinks, because that would be a whole different hour, but the most important change for children who are overweight and who have NAFLD is reducing sugar. And the sugar consumption in children is improving. It's not as high as it used to be, but it's still extremely high. So this is the first line target, reduction of sugar drinks. Low carbohydrate diet is something that's been studied, and it also was shown to have a benefit. And remember, the dyslipidemia, or the high triglycerides, also responds to a low carbohydrate diet. So I think that this is a win-win. And so sugar and carbohydrates are probably more important to focus on than a calorie reduction approach. And then I'm not going to show you a lot of data on physical activity and other dietary changes, but clearly improving vegetables and all the other things we know for childhood obesity would be important. One note on physical activity is that yesterday in the NAFLD symposium, we heard from a speaker who tested exercise in children, and it was 20 minutes of vigorous exercise a day from Monday through Friday, improved their insulin sensitivity dramatically. And so it's not a lot of exercise that kids need who have NAFLD, but it's certainly about 20 minutes a day, and it should be vigorous. So in summary, NAFLD is very common. ALT is the most useful test for screening, but we need to use gender-specific cutoffs that have been reset now. Excluding other liver diseases and characterizing NAFLD carefully needs to be done carefully, and it often requires a liver biopsy. For dyslipidemia, repeat the lipid panels and then treat the high triglyceride to low HDL level with a low carbohydrate diet as the first line treatment. And then finally, the first line treatment of NAFLD is lifestyle changes. Thank you.